talk follows a previous one that you might recall we hosted. Professor Kwizera Arthur hosted one in the a sad moment when we lost our colleague. And I would say that before we kickstart this, we give respects to Arthur, who was our really comrade and a life member of Uganda Medical Association, but also working at the AIDS control program administrator, was a husband and a father to other family members and children. So we will honor him and other colleagues who have passed on due to accident and the rest of Uganda. A minute of silence, and I think Andrew, you will help read with that. And once it is done, I will give the preamble and we start. Thank you. May our colleagues all rest in peace. All right, so Andrew, now we will start the webinar. Like I alluded to, this pre-event table talk hosted by Seed Global and the partners really is looking up tomorrow, where we have where we mark the Emergency Medicine Day through this theme from policy to practice, building a resilience emergency care system in Uganda. And for us to discuss trauma today and the days before, directly responds to this vision of the ministry. But as practitioners who are targeted on this webinar, others who might listen in, we have also witnessed a lot of trauma, especially on roads, but we also know that there can be other trauma experiences as the presenters will talk about. So this session is really timely and we'll be able to deep dive into the practical care because we want people to be able to respond when trauma happens. There will be other sessions, I'm sure, in the future that look across the pipeline from prevention to rehabilitation. But for this event, we are looking at the practical trauma care in our setting. And just for housekeeping, people need to know that we will award CPD points and we will need to interact. And of course, like I said earlier, today's information will feed directly into Emergency Medicine Day main event, which I would suggest that Andrew with Seed Global and other partners, maybe you use these for some minutes to tell people about what Seed Global is, who our partners are, and from that we'll go into the speaker sessions. Andrew, over to you.
Thank you so much, Dr. Asfas, and I know Commissioner will also speak more on this when he comes on. But we are going to be commemorating the Emergency Medicine Day tomorrow, hosted by the Ministry of Health with other partners supporting. And the commemoration event will start with a marathon, a walk, a march procession from the Ministry of Health at 7:30 a.m. in the morning, all through the Millennium Grounds, former KCCA grounds. And we really hope to have as many of you present at the venue. We really can't thank enough most of our partners. A few of them are listed here that on this flyer that I've put up: Seed Global Health, WHO, Malteser, UMA. We have other partners like Apple Global Emergency Care, plus training schools, Makerere University, Mbarara University, Lubaga, as well as Zambia. So we really hope all of you will be available. We shall be giving the match t-shirts in the morning and then we'll proceed. But for more, and I know for other high-level talk, Commissioner is on call, and during his remarks, definitely is going to highlight more about this.
All right, thank you. Colleagues, we dive deep, and the speakers are really well known to us. Of course, I and Andrew, we have worked with UMA for some time. I know Andrew now focuses on Seed Global, but I have remained at Uganda Medical Association as the chair CPD, but also the representative of UMA at the council. But our presenters this evening, Dr. Doreen Okongu is an emergency medicine physician. He's also an educator at Seed Global. Tom Bazanye is also an instructor. JP, we know, is our commissioner, JP Wanae, and we have Professor Arthur Kwizera, who is a consultant at Makerere, who is a professor at Makerere College of Health Sciences. We have Dr. Annette Arenyo Ngabirano, who is also an emergency physician known to us, and also a case management officer at WHO. We have Ambrose Naturinda, who is a regional technical manager, emergency medical services, and Miss Sylvia Natkunda is a nurse and an emergency medicine service focal person for the Mbarara region. So this afternoon, they have a lot of us of information to share with us, and we'll do much of the listening. And I want us to really begin by letting the speakers share with us in terms of how the emergency medicine protocols and the training and the response, the national policy and implementation, and their field experiences and practical tips that all of us might use. And I know, like Andrew alluded to, of course, the commission at the end will give the overarching ministerial position and what things might be planned along. But for these first few minutes, where we want to have the speakers just generally talk about this theme and how it relates to tomorrow, but also from the previous event that Arthur hosted just in the wake of the passing of our colleague. So Tom, if you're there, I don't know if you can hear me. I wanted to start with you. Tom, are you there? Or maybe Tom is not. So I would start with then the commissioner, Dr. JP. Would you then start this session and tell us how we build up towards tomorrow's policy discussion and how the things that the ministry is planning to do fit into this session, just in brief, because later on I will invite you again to speak about what the practical tips could be for health workers. But I want to invite you, Commissioner, to begin this discussion.
Thank you, our chair, Dr. Spa. Just first of all, good afternoon to everyone who is on call. We want to appreciate the team that has organized this, Seed Global, for your sponsorship, and all the various people who are on for their tuning in. Tomorrow is our big day of the International Emergency Medicine Day. The International Medicine Day is an important day for us to recall and look into how we are implementing the various policies towards improving emergency care systems in our country. As you all recall, the focus on emergency care system is recent development. The ceiling of this was when the World Health Organization in 2019 made a resolution 7216 in which they urged various countries to develop policies, strategies, protocols, actions, training capacities towards building the emergency care system. And this was based on the fact that most of the mortalities which were occurring were preventable. And a research done then indicated that 54% of these mortalities could be prevented by a functional emergency care system. And the emphasis was put on connecting the pre-hospital space with the hospital space so that you have the emergency care system which is continuous from the community up to the facility level until into the in-depth of the hospital critical care systems and so on. So this is what we are looking at. And as Minister of Health, from then on, we did the emergency care system assessment, identified the gaps. And then in 2021, we were able to have the emergency medical services policy and also the emergency medical services strategic plan. This has been followed by different guidelines, protocols, standard operating procedures, and training guidelines, which all of these together have formed what we see as the emergency care response in Uganda. It is a growing field, and we say there is still a lot to be done. Many of the activities or the achievements we have had has been a contribution of a multiplicity of partners, development partners, implementing partners, NGOs, the overall government led by Minister of Health, Minister of Works, Office of the Prime Minister, our security forces, and so on. I'll talk deeper into that later. Thank you so much.
Thank you so much, Dr. JP Wainaye, for giving us that introduction, and also sort of speaking to how policy translates into practice at the ministerial level and what tomorrow's events are. I think Tom is on. Andrew, if you are able to unmute him, since he's a trainer, him together with Arthur need to tell us, in addition to their tips, how the emergency medicine training protocols translate into real-world trauma. The two of them, I think, Professor Arthur is at Makerere, like I said, but Tom himself is involved in training. So I wanted Tom first and then Arthur to give us their practical tips, but as well talk about the critical care considerations as far as training in our country is concerned. So Tom, you can go first if you're able to speak now.
Thank you so much, and thank you, the organizers of this event. First and foremost, I would like to draw your attention, team, to the fact that we've lost quite a number of people as a result of accidents, but also other different forms of trauma. I come from the Association of Ambulance Professionals Uganda, and this is really about training, as you have put it. The association translates what the ministry agenda is into the practical aspects on how emergency medical services, from the policy into looking at what skills do we need from the members that are participating or they are part of the emergency care. We did not only look at the professional levels, but also the basics of what it means to save a life. From the years we have been in operation, we have looked at the different cadres from the basic first aid into looking at the professional standards of people who provide care. As the association, when we come to this day, commemorating the Emergency Medicine Day tomorrow, it speaks to us in terms of how much energy do we need to save a life out there, being that we are skilling individuals to provide care. The best thing is, do we have the communities or the professional people in the pre-hospital space able to save a life before this patient or the casualty gets to the hospital? So we are looking at, and all our efforts have been to provide that basic skill that would save a life before this casualty ends into the accident emergency area in the hospital or health facilities. I'll give more, maybe just to draw attention to the team here. When you look at the research done by our colleagues, Tony Rujia and others, of 2022, looking at the trauma unit admission at Uganda National Referral Hospital, where they're talking about over 54% of patients presented during daytime and 46% admitted in the evening hours. So these are traumatic, they are traumatic cases, but how do we have both during the day and during the night, not necessarily looking at one aspect of providing care? So it should be all around care, and our professionals should be able to provide this. I'll give more when I get a chance. Thank you so much.
Thank you so much, Arthur. Please take it on from here. I wonder if he needs to be helped to unmute.
Hello?
Yes, can hear you.
Oh, okay. Yeah. Thank you. Thank you, Dr. Asfa. Okay. Yes. Yeah. Thank you, colleagues, for bringing this event together. My specialty is obvious, is critical care. It's the tail end of what happens in emergency medicine, and my focus and passion has been about optimizing or making sure that all the pre-hospital, emergency, and then critical care work, like what we call a continuum of, I call it the chain of survival in critical care. And critical care starts, like Thomas said, it starts in the community. I don't know if I'm allowed, what I wanted to do today in this talk, because emergency medicine happens anywhere. It can happen on the ward, it can happen in the community, it can happen. And like Tom, who I've worked with before, alluded to, said, you know, the community is who we are. And I really thank the organizers for bringing this together. I don't know if I just wanted to, I guess, coming from the academic standpoint, am I allowed to share a presentation?
Sure, you should, because we want to give practical tips. Andrew or the other host could enable him to share his screen.
Yeah, I think I can. I think they have made me a host. So let me what I really want to do is to talk about the state of critical care in Uganda, to bring us up to date on in this regard, so that we can all be informed. I'm sharing right now. Just hold on. I think it's technology things. Can you see my screen?
It is on now. Overview of critical care.
Okay, fine. So I'm going to go as quickly as possible, because the Ministry of Health, after starting the emergency medicine division and so on, we've been trying to work together to also build critical care capacity. Now, all the work that the guys in the community, like Tom and the ambulance guys, do, and then the emergency medicine departments at the various hospitals do, invariably they do the greatest bit. Some patients will end up in the intensive care unit. Now, emergency care and critical care are they're so close. They're joined at the hip. That's why, for example, a lot of emergency medicine folk can work in the ICU, because our role in the ICU is really about organ dysfunction. So emergency medicine is about the first 5 minutes of someone's life, and then after that, the good work that's been done in terms of resuscitation and so on needs to be continued, and that's what intensive care is about. So having been part of the growth of emergency medicine in Uganda, and of course intensive care medicine, I just felt that maybe I should just provide like some sort of overview to a lot of our friends here on the history of intensive care and where we are headed. And of course, with regards to the work that the Ministry of Health is doing and others. So I'm in the Department of Anesthesia. I've just completed my PhD. I'm an intensivist, so I won't go very much. So the first ICU was in Mulago. And it was a renovation of an old unit that had been led by an old former anesthesiologist, and it was donated by the Japanese JICA. And Dr. Catherine Omaswa, Professor Omaswa's wife, was the first unit lead of that, because I think her and Professor Omaswa had come back from the UK, where they were both working and helped set it up. Later, LACHO and then IHK came on board and started setting up the units. In 2012, we had essentially one bed per 1 million Ugandans in the intensive care unit. So we tried to do a survey of what our country's intensive care capacity was, and this is what we found. So it really helped us get an idea of the situation. Now, however good you do your emergency care, because we were all in the emergency care space. You go to the emergency, you go to the casualty, then it was casualty, you resuscitate a patient, then what? Because you resuscitate them and you do a good job. Like, let's assume in the ideal scenario that Tom has painted, someone in the community sees a patient, can recognize a critically ill patient, can recognize or is at the accident site and recognizes this patient needs emergency care. They do their job. Maybe they apply a tourniquet, maybe whatever it is they do to stop and prevent what we call secondary organ dysfunction, because that's the role of emergency medicine. And then the ambulance comes on time, takes the patient up to the casualty or emergency department, and the guys in the emergency department do all the right things. If the patient needs a surgical intervention, the surgical intervention is done, and so on. But the patient still may, usually because of that trauma, has a host response, has an inflammatory immunological response to that insult, and they will need organ support. Essentially, that's what happens in the intensive care unit. But I was digressing, but this is what we found at the time. So before COVID, one of our students, Dr. Now the anesthesiologist at the Cancer Institute, Dr. Patience Satumanya, did this for her M.Med, and we said, okay, some years have passed. The government has tried to improve these things. Let's reassess and see what the situation is now. Nothing much changed because the population grew. So, and then they were setting up intensive care, emergency care is actually a very resource-intensive endeavor. Dr. JB will tell you that thing. And so when we were looking at where all these ICUs were, guess where they were? They were mostly in the central region, or in the capital. And I guess because of the nature of the resource intensiveness, yeah. Then COVID came. When COVID came, we'd been banging down the doors at the ministry. Dr. Zolaro and Dr. Atwini, I think, got tired of seeing my face, to telling them about we need to build more ICUs. COVID came. When COVID came, it helped us open up. And the Ministry of Health said, okay, let's take this on and to build ICUs around the country. So the focus was, let's do this for the regional referral hospitals. And I think some of you know that Arua, Hoima, and Kabale were the first recipients of this project. So I work with the Health Infrastructure Division at the Ministry of Health to deliver this as in an advisory capacity. And we're expanded. It's not just 10 beds. It's actually more than that. The whole units, we have dialysis, these are standalone things. And the goal is hopefully that the total number, at least the minimum number of public ICU beds by the time this project ends, will be 25. Now, we have others that might not be under the Ministry of Health docket, like the military hospital in Mbuya. They are going really big. And then, of course, it's been topical. Makerere, we are trying to set up a 8 to 10 bed unit at the hospital, the university hospital, the one just right across the gate. But even the planned Makerere University Teaching Hospital will have probably maybe another 100 beds if everything works out right. And then Loboa Hospital, as per the last time, I stand to be corrected, but as the last time the plan was for 16 ICU beds. So we're hoping that by the end of next year to have either in place or in progress at least 25 units around the country, but starting with the regional referrals. So I will not go much into this physiologic reserve and so on. That's not we all know what happens if a patient needs ICU admission. And these are the reasons what happens in the ICU. A lot of people know this. I'm trying to go as quickly as possible. This was a unit I ran at IHK. I built and ran this unit at IHK a long time ago. Tom knows. And this is your classical scenario. This was a trauma patient who was so lucky because he had trauma, was picked up within 30 minutes, was taken to, I think it was Mubende. And the surgeon there, or the medical officer, the surgical did his best part in terms of resuscitation. And then he was brought to us. He lost a limb, but among other things, I mean, he eventually even needed additional surgery. He had a craniectomy and so on. But this is a kind of setup. This is where we want to go. Ideal that if everybody does their part and the patient still needs care, they should. This is the ideal. This is what they should get so that they can survive. And this is the whole point. But if we do emergency medicine very well, this scenario would not happen. But if it was to happen, this is kind of the ideal setting. So you will see this patient was getting feeds through his, we were giving him parenteral nutrition. So basically feeding him through his blood because the gut was static. He was getting blood transfusion. He was on mechanical ventilator. He was in septic shock. We're giving him all these vasopressors to support him, but he made it out alive. You guys know in the picture in the middle, this was a COVID patient. I will not dwell so much on that. This was when we're in Mulago, it's our unit, but also showing that we can do the possibilities of critical care, neonatal intensive care, and so on. In the ICU, patients die. The whole point is making sure that one, they survive, and two, even when they survive, they can return to their previous life, their normal life as quickly as possible. We have two emerging things in Uganda. We have NCDs that are coming, and we've done research that shows that if you have an NCD, your chances of survival reduced by 50% if you need intensive care. Whether it comes from trauma or whether it comes from another insult. And the mortality trends, as you can see, for 2021, because of COVID, we all lived through that. It was very difficult. Our healthcare system was exposed in terms of the need for critical care. It's not a judgment. It's just we are a third world country. So the important thing is to have these conversations to build and find cost-effective ways of improving. So as of now, we have about almost close to 100 functional beds. And the things that we can do in terms of organ support, I've listed them. ECMO is essentially lung dialysis, for lack of a better word, heart and lung dialysis. I don't want to go into it, but it's just telling you how far we still have to go in terms of improving critical care capacity. So this is my home district. This is the emergency ward in my home district of Kisoro. I'm bringing you now around to what Tom was saying about bringing critical care closer to the community, whether in terms of training or resources. So we went to Kisoro and we said, okay, can we set up an ICU in the district? Or what's the best level of intensive care or critical care, emergency care we can set up in a district? Because when you bring it closer, then your chain of survival is improved because it's quicker. We all know the challenges. You get a problem in the district hospital, then they say, oh, refer to the regional referral hospital. We have to get the ambulance, then we have to get fuel for the ambulance, then we have to get, the challenges. This is not something I'm going to mince my words about, because these same things happen to our colleague, my namesake who passed. So if we bring these services in terms of skilling, in terms of equipment, in terms of even just an ideology closer to the community, can it improve outcomes? So I decided, I'm from Mfumbira, so I said, well, let's start, and the terrain is terrible. It's 80 kilometers to cover, about 80 kilometers to cover Regional Referral. If you guys have been there, you'll understand. So it started as it has started as a capacity building and a research project, because the research project was to understand what the best level of critical care without overwhelming the healthcare system would be. So we had all these target domains, infectious diseases, maternity, trauma, children, pandemic surveillance, cancer care, health systems financing, and so on. So, of course, as with all these things, we had to engage the district Ministry of Health, district leadership. They gave us the blessings. Then we had to get funding, and then we had to train people. Then we were given a disused building, and we set up this unit. And because you see, we don't know, and because the whole point was, what is the best that we can do at that level? So what we now know is that at the district level, we can't ventilate patients, mechanical ventilation, because we don't have the human resource capacity, but we can offer advanced respiratory support therapies. And oxygen itself is a very central focus of any emergency critical care. So if you transfuse, if you give someone red blood cells to move oxygen around, you also have to give them the oxygen, and there will be it will go, and hopefully we can optimize. There are surgeons, there are very highly skilled medical officers down in those places who can do a lot of these things, but they just need a little bit more. If you give advanced oxygen therapy, that's you're taking care of the lungs. If you can help them monitor patients, then in terms of respiratory support, hemodynamic, and so on and so forth, we now know that we can do these things. So this whole point of the conversation is basically to bring that to the fore. Intensive care is expensive. It's not something I would wish on somebody. The focus of the work that I'm trying to do is to find the most cost-effective methods of looking after our critically ill patients. And Uganda is trauma central. Every day, I think in Mulago, we get, I don't know how many head injured patients. And this is something that's happening all over the place, because Our young people are very mobile. They don't wear protective gear. They don't follow traffic regulations, and they're carrying passengers. So we have to have a holistic look at how we solve this thing. Yeah, and in memory of Arthur, I want to say thank you for listening. And if you have any questions, I'll be happy to answer them. Thank you.
I thank you, Arthur, for giving us the context as it is in Uganda, of course. Now we'll switch gears to ladies. We have Dr. Ngarano Annette Arenyo, who, in addition to her tips, would ask her to give comment on how WHO guidelines really are relevant in the context of Uganda, but generally for tomorrow's event. How do we build sustainable and policy-driven trauma care at the international level, like you are? Annette, over to you.
Thank you very much. Thank you very much, moderator, Dr. Asifas, and good afternoon, colleagues. So tips are very interesting. I'll start from a WHO perspective. So WHO, as has been said by previous speakers, recognizes the high burden disease that trauma is, and that it actually largely kills very young, productive people. If you walk into the trauma units, they are not filled with 70, 80-year-olds. They are filled with 20, 30-year-olds that are the productive part of our country. So keeping them alive and preserving all their limbs and life is quite critical. So as far as guidelines, we have a basic emergency care course, which is a frontline course for any level of health worker, and I encourage all of us to do this course. It has a trauma module that focuses on the key knowledge and skills that you need to manage trauma patients, including basic things like spine immobilization, etc. We also have a trauma care checklist, and this is something I strongly recommend. So what the checklist is a list of key interventions that should be done at specific points. There are interventions you should do after a primary survey. It double checks and reminds you. For example, is a monitor or pulse oximeter connected to the patient and functioning? Was there a need to do an ICD insertion? It reminds you of those key things that are very easy to forget in the heat of the moment, that is usually characterizes trauma resuscitations. This trauma care algorithm has 2 points where you check after primary survey, and then before the team leaves the patient, or either you're sending the patient to ward or to theater, again, it asks you to double check. Many times we've wheeled patients and then they crash on the way because we forgot to do some basic things. Or you're moving a patient, the oxygen disconnects and nobody's checking the monitor. So it looks at things like that. We have the checklist adapted also for mass casualty situations where it has key interventions, again, in the context of a mass casualty. We also have a trauma care algorithm, which combines elements of triage and ABCDE management. So it guides you on patient management from a trauma perspective. And then we have a facility MCM course, or facility mass casualty management course, and course materials and guidelines that guide facilities on how to manage a mass casualty. For example, if we have a mass casualty in hospital X, which patients access the ED, there are principles where the sickest patients access the emergency department, and then you can create surge space, say in the parking, for the uninjured or mildly injured. This is to ensure you have better utilization of your resources, because the emergency unit can become a bottleneck. Other bottlenecks you can have when you have a lot of trauma is the ICU that Arthur has spoken of. You also have radiology, which can become a bottleneck in patient management when you have mass casualties. And finally, the fourth is theater. And other work that we're doing is not specifically under WHO, but we supported the ministry, work collaboration with the Malteser to develop pre-hospital mass casualty SOPs that we are fine-tuning following a simulation that happened last week that some of you may have seen. And we tried to test a mass casualty in the event, for example, that one happened in Namgongo. Are the teams ready, and how would the guidelines work? So that is some of the work that is being done. We also have a lot of trainings and teams well trained in pre-hospital and hospital trauma care. Now, my tips, I'll speak from a very clinical perspective with my experience with trauma. If there is anything time sensitive, it is trauma. Trauma is so time sensitive, and the beauty with trauma, you don't need to think so much. It's not complex where you have differentials, 5 differentials you're choosing from. No, oftentimes, if you actually examine the patient, the pathology looks you right in the eyes. So take time and do a proper primary survey when you find your trauma patient. Check ABCDEs and identify immediate life threats and correct them as you move. The good thing with trauma, often you have a team resuscitation. So if one team is addressing airway, by all means, the next team can be inserting an ICD, another one is putting in an IV and pushing in blood.
Did we lose Annette, or it's my
My
network?
apologies. All that is cutting through.
Arenyo?
Sorry, I dropped off. Moderator, are you able to hear me now?
Yes, now.
Okay. My apologies. I hope you had the part of resuscitating as a team and doing ABCDE as a team, and that different people can focus on different elements of the resuscitation.
Yes.
Okay, excellent. The other is planning your resources. Your unit should be, so for primary survey, that goes through secondary survey, complete head to toe, front to back exam. That's where missed injuries really catch us. And you may move a patient with a missed injury that manifests when the patient is on ward. And then you have a patient crashing on ward, a ward which is not prepared to manage. The other is planning your resources in an efficient way. Have a clear layout of your unit. Small as it is, have a red area or a resuscitation area set out. You know that if a patient comes in who is multiply injured or severely injured, even with one injury, that is your place for resuscitation. In there, put your supplies, arrange a simple cut. It might then have to be a complex crash cut, but even a tray. But you know that if you need something on hand, it is there. And I caution other people in the units, don't go to resuscitation to pick fluids, to pick ETC, to manage green and yellow patients. Get those things in those spaces, because if you keep shopping from the resuscitation area, that is where you will struggle when you actually have an emergency and you discover people think you can go to resuscitation and pick anything and use. The other is layout. Again, have clear places for waiting, for yellow. It helps you think through your patients and how the patient flows through the unit. Ideally, resuscitation should be near the entrance to the emergency unit for those that have it, or the entrance to the facility. There are facilities where the resuscitation is 2 floors above. I've responded to an emergency. I entered the facility along the main road, but to go to resuscitation to the emergency area, you have to climb 1 flight of stairs. There is no ramp. You know, those are things we need to think through. Instead of putting reception at the front, put an emergency area. It makes logical sense. Be resourceful. Last week, I learned the strength of a pelvic binder. We're having a simulation and someone bound the pelvis with a fire blanket. And I told them, no, because this doesn't work. And someone else told me, no, it actually works. It's very strong. And we tried to pull through and it was very strong. So be resourceful, use blankets. If a patient comes in wearing heavy jackets, please take the jacket off, roll it and immobilize. Tie IV fluids together. But remember the principle is to immobilize. You don't need a fancy collar to immobilize. Blanket rolls, etc. Try to be resourceful with your patient. Tourniquet. I saw that very unfortunate tourniquet that we also last week. A glove cannot cause enough pressure, it cannot obstruct hemorrhage. Get someone's belt, get the patient's belt and tie a real tourniquet. If it's a tourniquet, it is something that can cause ischemia. So it has to be proper and obstruct. Close that tab. Refer early. The EMS system works, it exists. Yes, it has gaps and hiccups, but by and large, it works. Follow the referral protocol. Again, we can share all these documents. I know the ministry team has them. A clear protocol on how you should refer a patient. So many tips. Equip yourself as a health worker. Learn, go for trainings, practice your skills, be confident and be firm. If they tell you airway, breathing, circulation, don't be random about it. If you're alone, tell yourself, I'm now examining the airway. I've found nothing, I'm moving to breathing. I found this, I'm putting oxygen. The patient is tachypneic. I've listened to the chest. It sounds like this side may have, hemothorax. I've examined. Go systematically. Otherwise, trauma will catch you unawares and you lose your patient. And I know we are running out of time, so I'll give you the greatest tip. The greatest tip for me is attitude. Emergency care is a continuum. And if you meet the right people with the right attitude along this continuum as a patient, you will likely survive. You have to be on the same page as far as recognizing emergencies, as far as resuscitating your patient, and as far as a timely referral. Commit to your work. If you all said this is a polytrauma, we are committing ourselves to resuscitating this patient. Commit, be at the bedside, and resuscitate the patient. Be available, be responsive, document, and think through. If you can't, something doesn't make sense. The beauty with emergency care, you're not diagnosticians. There are many patients I've managed whose diagnosis I will never know. Some diagnosis you know the week after. It doesn't matter. If a patient is hypoxic, whether it's from trauma, pneumonia, they need oxygen. So follow those cues. You don't have to come out with a smart diagnosis. Manage what you see is killing your patient. And trauma is very clear. It doesn't, medical emergencies can be very shifty, but trauma speaks a very black and white language. So look, listen, examine your patient. Thank you very much. Back to you, moderator.
Wow, thank you so much, and for those tips, practical tips. And as you need to know that on this call, we have many other professionals, not only doctors, but the rest of the healthcare workers, the nurses, clinicians, anyone who could respond to this. So now I will again turn to Doreen Okong, to give us the tips, but also, speak about the trauma protocols and education, in addition to your practical tips. Doreen, over to you.
Okay, so good evening, colleagues. Good evening, friends. Thank you, moderator. Thank you, Seed Global Health, for organizing this important conversation. I'd like to thank my seniors who have spoken before me. They have laid the introduction in regards to the burden of trauma in Uganda. Just to give a background, I am in the educational and training space, but I'm also in the clinical space. And just to give you an idea of why it's very important to train, as Africa, and some of you might have heard of this statistic, that we only contribute 3%, 3% of the global skilled healthcare workforce. Let that sink in for a bit. Only 1, 2, 3. I don't know how much Uganda contributes to that 3%. So it just goes to show you that there's a great need for training, and not just basic training. We need advanced training. We need to have skilled health workers. And in order for us to save life, in order for us to reduce the burden of mortality and burden of trauma in the country, we need to be able to get to a point whereby we have the right people who are managing patients and managing patients well. Dr. Anne talked about attitude. That is just a start. But if you do not equip someone with the right knowledge and with the right skills to identify an emergency, then the patient outcomes are not going to be good. Right now, we only have a total of 21 emergency physicians in the country that have been trained. The program for emergency nursing is yet to start, but a lot has been done. A lot has been done in the training space. We've done training for paramedics through the certificate course at Rubaga. We've done training in short courses in BLS, ALS, PALS, etc., etc. The basic emergency care course, which is the foundational course for an approach to an emergency patient. So a lot has been done, but a lot needs to be done. There's much more work to do. And I believe that if we get to a point where we need to prioritize education and training, then I believe that we're in the right step to prioritizing better healthcare. We need to get to a point whereby we get to understand that in order for us to transfer a skill, for us to transfer knowledge, it requires an investment. Education is an investment. And this is transferable. This is transferable from one person to another. The skills that you pass on, the knowledge that you pass on is going to save a life. You don't want to get to a point whereby it could be any of us on that emergency bed, and you go back and think, how I wish I had trained this person who's working on me better, or how I wish I had passed on the information I had to this person to save a life, not only my life, but it could be someone else's life, your loved one, a neighbor, etc., etc. So it is very important that we prioritize training, and not for one particular cadre. This training has to be cut across for different cadres. The practice of emergency medicine is teamwork, essentially. You can never resuscitate a patient just by yourself. We cannot continue to emphasize team dynamics in terms of resuscitation. You need a nurse, you need an EMT, you need senior doctors, you need junior doctors. All these cadres come together in order to save life. So it's very important that there has to be prioritization of training in different spaces. A lot of short courses have been rolled out in the country. However, in other developed countries, there is training that even goes back to children, that goes back to the community workers. In developed countries, I believe it's Germany or somewhere in Europe, where you cannot get a driving license until you've done a course, I think in first aid or something like that. So why can't we have that? Why can't we have formalized training? Why we can prioritize going to learn to drive a car, and you get a card that shows you've gone through a certain training that allows you to do a skill. So how come we cannot prioritize our health? We can't prioritize life, So we should have these conversations for us to put the word out there that we need to prioritize, safety. We need to prioritize health. We need to prioritize life. And these conversations are very important because policy change, system change, it all starts with conversation. The training need is still high. I will still re-echo this, that we only, as Africa, only 3%. So I don't know how much Uganda contributes to that. So there's a lot more to be done. But that means we need to also understand that in order to train, we need skilled people who are training. So we need to be able to invest in people who are going to pass on these skills, who are going to pass on this knowledge. There's a lot of open source information. There's a lot of literature that has been published. There are a lot of things you can download on the internet. But there's something that we learn, and something that I learned. I'll give you my personal experience. part of my practice is tailored on mentorship. And some of you on this call will agree with me that mentorship is very, very important. Your attitude and how you approach patients, how you approach your practice is tailored on who mentored you, on how you are mentored. In the space of emergency care, we need more mentorship. We need more people who are going to lead the younger generation, to guide them, to advise them, and work with them so that the approach to emergency patients can change. There's a practice amongst healthcare workers, and it's a very sad practice, that the sickest patients are usually the patients that people tend to shy away from. You go to emergency department and people are running away from the sickest patient. You know, it's quite sad. And I'm not sure if it's the attitude or it's the laxity or it's the lack of training on the management of these critically ill patients. That has to change. That really has to change. And so mentorship is part of the solution to investment in qualified trainers. The other thing is conversations that are going to prioritize the importance of life, the importance of health, the importance of skilled health workers, the importance of training that is going to improve patient outcomes. Those are some of the tips that could help us in the training space. Thank you very much.
Thank you so much, Doreen. We will now turn it to the nursing care. Sylvia, are you on?
Yes.
Yes,
Please.
Yes, we want now to turn over to you to tell about, to give us tips as regards nursing perspective, but also given your role as the regional integration, you know, on the regional level for Mbarara. Could you give us tips relating to regional implementation of the EMS in Uganda? But your tips first, over to you.
Thank you so much, Doctor. Our moderator, my seniors, colleagues around, our commissioner, and the mentors. I'm proud and happy to be part of this session and proudly say that I was mentored to emergency medicine quickly as soon as I was inducted into public service. So as I said, I'm working at Mbarara Regional Referral Hospital. And again, I'm the EMS coordinator for emergency medical services, Mbarara region. So I coordinate pre-hospital care, and throughout my public service I've practiced, I've been more engaged in pre-hospital care and frontline in the hospital as well. I do both. So the tips I can say, maybe let me first with the tips, so that those are the things that they will help you to do everything you can. You must have attitude. Without attitude, you cannot do anything on anyone, whoever you meet around. If you have a negativity of everyone, whoever you meet and you feel like he has talked bad, I cannot give sacrifice, may not do so. As health workers, attitude is the one that is making us not to do a good service, because we feel we are tired, we are demotivated, we are working long hours, we don't have an identity of saying, can I make this sacrifice on this individual who wants to have a life? So as nurses, I'm sure nurses, we are a big percentage in hospital. We do a lot of work. We work long hours. We have a lot of occupational hazards that we have. Many nurses have had backaches, but in issues of trauma, as my colleagues have stated, it's something that you can work on very shortly, save a life, and hand over to another person. So if you are this nurse, we are always the ones on ward all the time. It's your shift, you planned it for 8 hours, and as soon as you're leaving the room, a trauma patient arrives and you feel like I cannot step up a leg back, just know that you've lost a life. But as I said, if we believe that this patient has come into my hands, I can resuscitate for 30 minutes. You can resuscitate and you hand over to another shift and you move away. Again, you have to be skillful. You have to have skills. Dr. Doreen has said she can't tell why people run away from sick patients. They are right. You cannot work on a patient when you don't know what to do. So as nurses, take an example for low facilities, us who work in high facilities, regional referral hospitals, we have volumes of people who are experts. We have SHOs, we have consultants, professors, medical doctors. But if I can talk about nurses who are in the lower regions, district hospitals, health center 4s, health center 2s, health center 3s, trauma doesn't segregate that it will not get a patient from home. Someone can have a snake bite. Someone can fall from the what? From the bathroom and get head injury. That is, so the best area where they can run to, it is a health center 2, which will be near, or health center 3. So as a nurse there, and majority, you find the nurse there, the midwife there, the doctor you find at health center 3. So as nurses, as midwives, as clinical officers, we are the frontliners, and this is the time we have to accept that our training scale is not like at the doctor's level. To be honest, someone at health center 3, right now you find maybe if she has been aggressive, she has bachelor's, but majorly we always have diploma and certificate, and we know the practice, our content we get at certificate level. So with the coming trainings, as other speakers have been saying, B.Ed, LS, BLS, you have to be aggressively to acquire such opportunities. If you cannot, just know that you are going to make people lose their lives as soon as they can. But if you have acquired a back training, even if you are at a health center 3, you have the capacity, you have the lines, you can easily know that this patient needs blood, ask for blood group. Even in your notes, you can even find you are doing a great work, you know what to write, you can easily document right things. So we have to be aggressively invest in ourselves, acquire skills. It can be through hard work. If you work hard, you can be identified by your leaders and taken for trainings, or such trainings that are coming up. You can invest in yourself, get to some money, get a skill. That is if you have an attitude to practice a good nursing area. And you have to get knowledge. Another tip is you have to be mentored. If you accept that, you have to get people who inspire you. Personally, I can say I was inspired by Dr. Nate. Ever since I met her, my life has changed because she really helped me to identify my skills, and she could tell me, but I had to go there and ask her, why do you like looking for me? Till she said, so you have to get role models. You have to get people that in your region. When I reached Mbara, Dr. Priska called me and I was shocked to find a doctor is looking for a nurse. But I felt like I'm blessed and I remained close to her and she has mentored. So as nurses, we have to look for people who are very good, nice, and we also get role models and accept to be mentored. Another one, you have to be flexible and accept change. Nurses, we have failed to be flexible. We are people who are rigid. I've not seen it in any training school, but we are very rigid people. We think what was practiced 20 years ago before I joined nursing, it will be practiced today. As Commissioner said, EMS policy was launched in 2021. So if you've been practicing nursing for the first 15 years, you've not heard about emergency nursing or trauma, these things of emergency medicine. But now, before your retirement, if it has found you in a scope of practice, we need to accept it. We need to adjust our setting and work and be able to learn. So those are the tips as we can. We also have to work as a team. These things of trauma, you cannot do trauma alone. However much you nurse on shift, many times, me part of pre-hospital care, I alert a team at emergency at ED when there is one nurse working on about 20 patients who are on trauma, very sick, and I'm bringing in more about 20 casualties. Maybe these businessmen who've been moving around, the tourists collide, so we have a mass casualty, and I tell you, we are bringing in 12. So at that time, you cannot say, I'm going to work on those patients. Even the time your doctor will find you, you are calling, oh, he's there with you. You two people, three cannot work. So the only thing is, if we have a good teamwork at work, you love one another, you can easily activate your own colleagues who are home. They will come running because they know my colleague has entered into a high blood thing and I need support. So, but you cannot do that if you are at work and that runs team leaders in those wards. If you are the in charge, you've failed to create a ward that has a conducive atmosphere for every nurse who is working there. Feel like I should do and I should work with my colleague as my brother, as my sister. I need to help this nurse on duty. We work together. Same applies with doctors. If you're departmental area managers, and you cannot make a unit unite with the staffs. In cases of mass casualty, we normally find one people working on a patient as if they are working on alone, yet the timetable has about 11. Why can't you activate those 11? They come and help. And remember, trauma can take someone in 30 minutes. To my people who are outside government hospitals, they are in private practice. If I forget, we need to accept that we may not do everything, however much that we need money, but we have to accept that some cases we may not have thorough assessment we can. We are picking many patients dying in clinics because people want to be retained and be monitored, yet you are monitoring someone who gives a history of trauma, has a ruptured bladder, and you have maintained someone at your clinic for 2 days. Someone tells you, I'm not urinating. You continue saying you are not taking fluids. A patient is drinking, but someone is not recognized that I have a problem. The time we reach the referral, they tell you someone wants to have an emergency X-lab. So it's hard. We have to adjust ourselves. Then another one, but we have to be change agents. You've trained, Dr. Reni has cited, we are training people would say we are training. Yes, we know that you have trained. But those people trained, when you go back to your facilities, are you able to make a change? I remember when I was in Ginger, I did because I was just from a knowledge. By the time I saw Bell, I was like shocked. I realized that I didn't know things in school, but this knowledge I've got, can I take it back? And so if they are a skill of a Josephus, that you are not going to change the insertion. You cannot go back to ward and see in my room, in my ward, do we have an OPA? Can I ask the in charge that this thing has an importance? And if you are given that equipment and you receive that patient who needs it, are you able to practice it? If you come back, we have so many people who are trained, they have their knowledge in their head. I don't know if it's, but they come back, they remain the same. They are not making any change. So the protocol remains the same. You left the ward without an oxygen supply. You come back after the back training, you cannot look an nasal plug. You cannot look an oxygen cylinder and put it in your room. So everything remains, however much ministry will invest in you, give you skills, you cannot change. So as nurses, we need to be change agents and other people. Leadership. Nurse leaders, we need to support our nurses. Make your teams get motivated because everyone is at the potential of getting trauma. So if we are, you know that you are the people who knows how many people have been trained. You know, I have 2 nurses in emergency or OPD, and they are the only ones trained in a resuscitation. You either advocate for more others to be trained or make use of those 2 to train the others. So that the time you make a changeover, you know that I am taking one of these 2 nurses, surgical ward, to do other trauma-related cases, but again, you know that you are replacing someone at the ED who has a skill, but don't get someone who been in eye department, skin clinic, and you bring that person to emergency because you have seen this nurse at emergency has a good attitude, she's flexible, she's working long hours, she smiles well at patients, she gives sacrifice, and the end you think they will come and tell you people poison others, that this nurse is working hard because she's earning a lot of money from these patients. It's not like she's working under influence of money, but she has a zeal, she has an attitude, she has been mentored, she has acquired skills, and she feels I need to save her life. So before you make a changeover, know that you are replacing someone with a similar skill, and the other person going that side can have. Probably for them, take them for workshops, then that's all. Part of pre-hospital care, we agree that many patients are dying a lot in the field. So as the community in Uganda, we need to continue community sensitization. We have picked many patients. Personally, I move on ambulance, so I have that experience on the scene. We have picked many patients dying in clinics because they feel they are comfortable there, and those people are persuading them that we are managing you better way. Yet they cannot understand. They complain to them and say, I have this problem. They will say, don't worry, you are going to be okay. Yet the clinic cannot manage. The time they see their patient is not changing, it's getting late. So as the community, we need to sensitize a lot of the community because trauma needs high-skilled areas and also needs timely interventions. Also, we tell them maybe if you are being involved in a high road accident, the mechanism of injury is very much sensitive that needs a specialized area, cannot run like a simple clinic. So we need to educate the community about trauma in its advanced areas. Also, we need also to empower those people in the health centers, as we have said, because those are the people where we first get first aid. If they are not educated enough, resuscitation becomes bad. So as someone said, I think it would be nice if every health worker is mandatory to take a BEC course. It's a change agent, and regional supervision can be done. Another thing, as our commission is here, we need to make these people make use of our ambulances. Yes, we accept the ministry. They have helped us. They have given us many ambulances in the area, but they are getting spoiled very soon. So in the long run, about 25 years, you find where you've bought about 10, you have 2 ambulances. So we make use of the vehicles given and also empower the leadership to support EMS. We are still lacking leadership support. EMS, these drivers are not trained. The few trained are moving without health workers. Of course, we know we have shortage. However, we need to continuously motivate people to sacrifice and work, because if a driver runs alone on another tier, you will not save a life. He has picked someone bleeding, is in front driving, no one is behind. The patient is pulling a leg here. The time you reach the hospital, the one that was halfway broken, it is fully broken. So we need health workers on ambulances. We accept the government has given ambulances, but we have not had any recruitment in supporting those ambulances. So the ambulances are being given, but without health workers. If we cannot have them, let's support the ones who are in the facilities to give an extra hand and support. And that is all about leadership. They are the ones who can motivate that. Otherwise, I thank you so much. We shall continue.
Thank you so much, Sylvia, for that regional context and nursing care, but also, talking to the commissioner directly. We need to train more. We need to do more. Ambrose, you have to conclude the first phase, and you must tell us some of the practical experiences in the field. I know that also the election or selection period is coming. We are going to have unique kind of trauma. Stabbing, stones, and also maybe also again RTA, the accidents tend to be common. So Ambrose, could you now conclude this phase by giving your tips, but also responding to that comment? Over to you.
Okay, thank you, Dr. Cephas. I don't know if you can hear me.
Can hear you and see you clear.
Okay, thank you so much to every panelist and participants on this session. And I would also join my colleagues to say that this session has come on time and in hand. Just starting from where you stopped, or the question you've asked. As someone who has been in the field and the system ever since it started as an EMT, a lot of things have changed and have evolved. So as we come now closer to the elections, we are just feeling now the fever of election period. And of course, a lot of accidents are also happening. We've had a lot of so many fires and even other trauma cases, falls from the heights. So as pre-hospital team, we need to be ready for each and everything. However, as you said, I need to start with the practical tips. Your safety is always number one. Whoever pre-hospital care provider is on this call, always prioritize your safety. Please don't die as a smaller hero. I always have that quote every time I talk to my people. If it's not safe, please don't go in. Wait for the responsible agencies, especially security, police, maybe if it is fire, wait for fire brigade to secure the scene before you enter in. And let them be the ones to tell you that now it is safe for you to handle the patients, or else let them rescue, extricate the patients, pick them and bring them to the zone, most probably green zone, where you can work on them very well. Number 2 tip, remember every time you respond on now the accidents or road traffic accidents, after you've ensured that your safety has been secured, don't pick, load, and go. We've changed that. Now you have to reach, stay, play, then load, and continue with care on the ambulance. Please always at least try to provide on-scene care. Now, in the context of road traffic accidents, right? Make sure at least the patient, before he's scooped from the ground, is stabilized. Is for all road traffic accidents, patients, at least whether you've found it or not, let's have a pelvic binder on that patient. It's good to have it than not having it. Then you realize that by the time you reach the hospital, the patient has bled out to death. Let's secure the C-spine. Let's immobilize the full spine on the spine board, strap the patient very well, and administer oxygen. And why am I saying that you administer oxygen? In the context of breathing, we are losing out, of course, oxygen molecules. We need to supplement what is still remaining. And in that line, in pre-hospital, we always say, please don't treat machines, treat the patient. Treat the patient as he or she is presenting. Don't treat what you are seeing on the monitor. I hope that one is clear to all my colleagues in pre-hospital, so that we don't normally base on what we are seeing on the monitors, on the pulse oximeters, on the BP machines, but how does my patient present? Also, another tip, as you respond, because you'll be called by call and dispatch or the REC or police, whoever will call you to respond to an emergency. Always expect the worst. Don't say, they've said that the patient has been knocked and is just down crying of pain. But respond expecting the worst and do your best. If you find that the worst case scenario has not happened, but now you have enough resources to do your best and arrive at the facility with a well stabilized patient. Another tip would be, as other panelists said, please don't try to diagnose. Stabilize the patient and go to the facility where the patient can get a definitive care based on your decision and based on how the patient is presenting. For example, if someone, you've realized that he has signs of head injury, signs and symptoms of head injury, why would you go to a health center for? You rather move a longer distance to go to where the patient can get at least the neuro services, maybe neuro surgery, if it is needed, and the CT scan. Yeah. Instead of now wasting more time of the patient that you would have benefited from the specialists in that area. Another tip to all pre-hospital care providers from me, and for the time we've been working in the pre-hospital system and sector, always make sure you've stocked your ambulance at least with minimum required supplies, so that by the time you have the patient, you don't start now rushing. But now you see the oxygen is getting done, you tell the driver to give fuel bolus. Yeah, we call it fuel bolus or diesel bolus, right? To rush so that you can reach the hospital as soon as possible. And I would like to tell everyone here that speed doesn't cure or treat the patient. It's the services or the care you provide to the patient that will help the patient to overcome the anticipated complications. Another thing is that Sylvia talked about ambulances being given out to the districts, the constituencies, which is very good. Now we need to think about those people that are receiving ambulances. Do the drivers have required training? How about the nurses or the providers that are being put or recruited on those ambulances? Because we need to give also the accountability of the resources we are giving out in the constituencies and the districts. Maybe my prayer would be, can we identify a driver and also maybe the nurses that will be manning that ambulance to be trained before they start using the ambulance, because the equipment are going to be destroyed. And also, even its ambulance itself, we've had different incidences where new ambulances have crashed beyond repair because maybe people were excited and didn't know all the dynamics of handling an emergency vehicle. That is my prayer. Another thing is that for pre-hospital teams, always please be resourceful. Remember, in pre-hospital, you are everything. You don't, they will tell you it is a road traffic accident. You reach there, it is a mixture of so many things, right? Dr. Annette talked about use of shock blanket for pelvic binding, right? Still, even shock blanket can be used as a tourniquet, right? So be resourceful so that you can provide adequate and essential care to the patient that is needed most. Another point in that context would be that in emergency medicine, especially in pre-hospital, please don't cram things, right? Do a lot of research, read, and read. And in pre-hospital, you have to be a hands-on person. Your vocabulary, your knowledge in your head, but you can't tell the patient binder that please apply yourself, right? So you need to practice as often as possible and have all the skills on your fingertips, plus also the latest knowledge. Medicine keeps on changing, and we need also to change with it. As also previous panelists said, attitude is very, very key. And I would add also passion. You can't work in pre-hospital or emergency field if you don't have passion for it, and also you have a negative attitude. You need to be free, be flexible to work even extra hours that you not even demand for overtime, because it should be within so that you are able to treat your patients and feel like even
If it is me or others unable to hear
above
ambulance,
all,
Network, not
above all, always, as Dr. Ann said, document everything you've done, everything you found, because the doctors you're finding at emergency department, they were not with you in the field, right? The way you found the patient, you need to rate it. What you've done on the scene, what you've done in transit. The doctors, the EM physicians, the nurses, whoever will be receiving this patient would like to know what you've done, what has changed. Is the patient changing to the best or to the worst? So that can determine how to continue with that care, right? And I know all ambulances in Uganda, they were given patient care forms that they're using. If maybe others are not having it, it is very, very important also for follow-up of those patients. And of course, always hand over well. Proper handover of patients at the emergency department is very, very important. Don't just dump the patient at the emergency department and you say, they've Late to receive the patient may have gone away. Please stay with the patient, even if you are to stay with that patient in the ambulance until the emergency department or the receiving unit is ready, please do so. You rather stay there the whole day, as we used to have it even during COVID. You would stay there for long hours because they are not yet ready. And you know, by the time you leave that patient somewhere, the patient is going to die. So you know where you picked that patient, how the patient was looking like, how the patient was presenting. Please do a proper patient handover to the right teams and make sure that the doctors or the doctor receiving the patient has signed your patient care form and you've agreed on everything that was done, and leave that hospital leaflet to the hospital and go with your triplicate. After you've handed over, in Uganda we are using ISBAT or DMIST, depending on how you were trained, but pre-hospital teams normally use DMIST. I will not go into that details. As ambulance teams, remember, all of us were potential casualties. All the cases, all the accidents we've responded to, we are all potential casualties. Decontaminate your ambulance. Make it ready for the next call. And next patient might be you, your child, your husband, your wife, or your relative. So let it be ready and should remain clean. Let the equipment be well organized and maintained, and use right chemicals to disinfect and decontaminate. The good thing, there are good protocols on that, on IPC, decontaminating ambulances in the National Ambulance Norms and Standards. Then in a situation where we have now the REX and call and dispatch at Naguru, please report back that now you are ready for another dispatch. But always make sure in the Ugandan context nowadays, the ambulances which are based at facilities, you need to make sure that you've restocked your ambulance because you never know when you are going to respond again. You need to restock the supplies you've used. This is very, very important so that you don't go empty-handed and you reach there, you get surprised. Or you reach at the facility, they tell you this is the patient, or I don't have nasal plungs or non-rebreather mask to support my patient. That will be on your side. And we appeal to the government at least to apportion some budget for ambulance restocking and have enough fuel, at least for the common person on for in the community. Lastly, is that, as Dr. Dorin said, that now in Uganda we're professionalizing the pre-hospital field. I encourage everyone who is working on the ambulance right now to interest him or herself to go back and at least get professional training. Yes, at Lubaga, we are training EMTs, basic and advanced will be starting soon. And for your information, at least, I know Commissioner will talk about it in the last strategic plan that is maybe going to be reviewed. They wanted around maybe 5,000 EMTs by the end of this year. But apparently, I think we have 22 have just finished their exams, final exams, waiting for the licenses. Yeah. So those are the tips. I don't know, Mr. Moderator, if I've answered all your questions.
Thank you so much, Ambrose. I mean, technically, this is the first cycle, and I know the last one is going to be very, very brief, but I had just two questions before I transition this to Andrew. One is to Tom, but the rest could later on chip in. But Tom, briefly, I wanted to ask you, how do I transport a trauma patient without ambulance, with my car, with my boda? How best can I help without an ambulance? And then the second one for the commissioner, what is the pipeline for training and hiring emergency care providers in this country? What is the outlook like? I think to me, if I am going to start school and I want to join trauma or critical care, not trauma per se, but I would want to understand from training, what is the pipeline like at the entry throughout the positions that exist in the public and private sector? You are the commissioner for both private and for public and private, so you should be able to give us an oversight or an overview of that. So Tom, with you first and then the commissioner next.
Thank you so much, moderator. You have really a very nice technical question. I will also respond it according to the technicalities involved. How do you transport a traumatic patient using your own car? If we look at, let me use the emergency care framework for WHO that talks about the event, transport, and the other monitoring and evaluation until handover. In as far as the EMS, the emergency care framework is concerned, and the event in this case is trauma, it is not advisable to get somebody, for example, somebody with mouth fractures, then you put them, or you struggle to put them in a car that is not fit for transport. Then you are doing more harm than good. Chances are that this casualty will not, you'll pick the casualty alive, but you might not deliver this casualty alive in the accident emergency area of any facility, given the fact that if somebody has had, for example, cervical spinal injury, and you try to figure it out and put this person in the car, chances are that you might have call it vegetable at the end of the day, or you'll have somebody who is having paralysis because of what you'd have done during the transportation. So ideally, we should look for ways, better ways to transport this patient. And this is what I can say is we are also having a course specifically on how do we actually get this patient from a wreckage, because transporting is as good as removing this patient from a wreckage, which is ITLS access, which we are going to be rolling out with Uganda Police. So, moderator, allow me to answer that way. Thank you very much.
Thank you. I hear you saying we should do as much as possible to seek the ambulance or people who can do this better. And I think then for our communication beyond here is to make this message go away. The background to my question was often on the scene, it is another transporter or a border that's responding immediately after the accident or trauma, and then the skilled personnel later. So that was the background, but I have the answer. Commissioner, how do you respond to my question on the pipeline? Because This informs how many people are going to enroll and in any case be retained to deliver service. We agree that it is needed, but could you highlight what the ministry or the government is doing? Over to you. I wonder if JB had, am I audible? Andrew, can you hear me?
Yes, we can hear you.
Or maybe Commissioner might be engaged, but in any case, I also wanted to say that Andrew is going to continue with the remaining part of the segment, and maybe I should take this opportunity to show face. I have a face, colleagues. I am Aspas Waraganisa. I am happy to have participated and from UMA and other colleagues from the other professions. I thank you, but I will now hand over to Andrew, but I will also request that you let me sign off. Over to you, Andrew.
Thank you so much, Dr. Asfas, for your time and really leading this initial part of the discussion. I wanted to create an opportunity for our listeners to kind of, if they have any specific questions, any specific areas where our panelists for our table talk today could come in and clarify. You could do that by putting your hand up. We should be able to pick you up and you speak. And then we should be able to close at the top of the hour. So we'll start with Dr. Kaweru. You're welcome.
Thank you very much, Dr. Asfas, Dr. Venamus Kondro, and the senior colleagues who have actually been on the panel, or the panelists. And thank you for giving the hints. As I teach undergraduate and postgraduates in Makerere and Mulago, there's always a question I ask. Suppose I get an accident, or I intend to get an accident outside Mulago over the weekend. How can, not intending as such, but suppose it happens, and it may happen. What have we learned and how have we prepared in terms of collaborations with the different institutions? Dr. Arthur, you've been teaching in Makerere for a long time. How have you scaled this to up-country settings? And how have we collaborated with the Service Commission to make sure that they employ people? And how have we also integrated the EMS with the different clinicians, apart from transporting patients who are critically ill, and then linking up with the critical team? How have we involved the other on-site people, like the clinical officers who are up country, the MOs who are up country, and from the different universities? Because at the end of the day, that may give us coverage here in the urban settings like Kampala, and then the rest. So, our dear Commissioner JB and Dr. Alinyo and the other teams in EMS, Dr. Kwizera, how have we prepared ourselves to move that direction? Thank you very much.
Thank you so much. I wanted to take more questions, like 3, before our experts can come in. Julius, do you want to speak? I see your microphone is open. Gibutai? Oh, okay. Colleagues, do we have any other comments or questions from the participants who are listening in? Feel free to put your hand up. But as more are putting their hands up, perhaps. Emmanuel, do you want to speak? I see you're unmuting.
Yes, I have a question. Thank you so much for the opportunity. Thank you for the seniors for the presentation. Akati, I have a question or a compliment or a supplement. Since the most of our casualties are being referred from the lower
Manuel, we seem to have Manuel. Okay, I think Manuel will come in later. Let me pick Adedeji as the last one, and then we can have the responses from Arthur, Alenyo, and probably. And those who are putting in the chat, thank you so much. I'm seeing Onen Tony saying, can emergency care training be incorporated in the curricula of all health units plus the armed forces? I don't know who will respond to that, but I'll let it open to our experts. Julius, come in and speak.
Thank you so much. I hope I'm audible now. My small inquiry was even put in chat as we are waiting for enrollment or employment of more emergency responders. Is there any way, if someone else work, for example, I'm willing to volunteer, is there any way I can be incorporated into the Ministry of Health emergency response team around Kampala, because they stay around Kampala? Thank you.
Thank you. I'm not sure who will respond to this, but Commissioner should be able to respond to that. Lastly, let's have Arnold, and then we can open it up to our experts to speak.
Okay, thank you, moderator. I'm Arnold Ashobia, an anesthetist, and my concern or question goes to maybe the Ministry of Health. Currently, I've heard that we have around 21 emergency physicians trained, and I happen to be at the facility where I think by chance we have one who doubles there as an emergency physician, and I've seen a great work he has really put in. That's Dr. Bashir Luzige, and since he trained, I saw a lot of things happening at the district hospital, at the general hospital where he is currently. And I've seen how he has changed. I have heard somebody talk about the problem of the structure itself being funny, that you cannot reach the Center for Resuscitation. And I've seen how he has put much more input, to the extent that they have obeyed to break and change the structure, that they build a more comfortable system. And I'm wondering, for those a few people whom we had for now, how does the ministry plan for them? Because if at all they are put in responsible places, we personally would benefit from them, because I've seen a lot of us gain skills from such a people. Can be one person at the center or at the station, but then a lot of people, the nurses and other people around the same hospital, may really benefit from such a person. How is the ministry planning to utilize those, and currently where are they? And I think that's my concern.
Okay, thank you so much. So in no particular order, I'll ask the experts to come in and respond to the specific queries that were raised or questions that were raised towards them. And I will intentionally have Commissioner respond last, who will also close our webinar today. So we could start with Dr. Arthur, and then Doreen, and then we'll call in the rest of the experts. Just those questions specifically addressed to you. Dr. Arthur.
Yeah. Thank you, Andrew. The journey. First of all, I'm very glad that we're having these conversations, because this is what development is about. When we are trying to build capacity for acute care, which is emergency and critical care, these are very important conversations to have. I'm speaking from a philosophical standpoint, because of the fact that working with the ministry, you get to realize that there was a time the resource limitations that we have. There was a time we had nothing, and then we're starting to have something. And I really, really, first of all, want to applaud the other speakers in this space, because they have been very, very active in this space. And I want to speak specifically to Ambrose and Sylvia, and say, you guys, thank you so much for the work that you're doing, and everybody else, because you don't understand how we were 20 years ago. And that 20 years ago is when I finished, I think I had just finished my internship in Hoima as a medical officer, and then became a medical officer, and things were just different. I've had the privilege of being actually a helicopter emergency doc in Europe. I've been on helicopters retrieving patients, doing stuff, and so on. But when I have spoken to my seniors then, the time I was doing that work, and even in war theaters, Iraq, Afghanistan, wherever, you learn to understand that. I asked them, how did you get to this level? And they always say, well, we've had a discussion, which is what we are doing today. We had a discussion, then we did research, we used the research evidence to build everything. And of course, healthcare financing was very big to build everything. We're talking about ambulances that can't be fixed. But these guys, their problems with helicopter, the rotor is what needs to be replaced, and so on and so forth. So different problems, but the principle is still the same. We have a discussion like we're having today, and then we start to build and keep talking to each other in this aspect. Sometimes when I'm involved in the Ministry of Health with Dr. JB knows, I feel sorry for them, because sometimes the burden is too much. We want to move we're a third world country. We want to have first world aspirations. Sylvia talked about something very important, about the importance of attitude. But I think that we need to learn to do what we call frugal innovations. Like Dr. Ann, like Ann said, in your space, organize your space, be organized. With the little that you have, you do that. Wilbur talked about how to integrate. I think having it, I always talk about, I have a paper coming out, and it's talking about the chain of survival. And the chain of survival is from the community all the way to the last, and maybe back to the community. It means from the community, they identify you have your trauma, you move, then in the health facility, then the health facility recognizes that, okay, we may or may not manage this patient, then they refer. And they have to know how to refer, where to refer to, because of the space that this is in. And then that referral point then manages the patient, and God willing, the patient survives. If they need ICU, if they're not, they survive, and they come back to the community. So that is the chain. It's actually a whole loop. It's a cycle. So the discussions that we're having, I try to tell people, let's not lament so much. Let's appreciate where we are at our level. Let's understand our level, and then start to build on those things. The integrations that Wilbur was talking about, we are coming together. So Mbarara was the first to have an emergency medicine specialist program. There was, I think it was Nyashibali that have the diploma program, and then Ambrose has alluded to the EMT program and so on. These things need money. They are not cheap. I keep saying this in emergency and intensive care is a very resource intensive. So we're talking about 22 when we have an aspiration for 5,000. We need to keep telling the government to apportion a lot more resources to emergency care. Because if we do well at the community, the district, and at the lower levels, it reduces the time and improves outcomes. And even the need for intensive care will drop quite significantly, so that the need for intensive care is only if it gets reserved for the things we can't avoid, mostly genetic and infectious diseases and so on and so forth. So I think that's my take. I'm just glad that we're having this conversation. For me, having this conversation is the most important thing. And our leaders here, Dr. JB and all the partners here know this. So we're having this conversation. Let's keep talking, and and I really like that people are in their various fields are showing leadership. With the little that we all have, are showing leadership in this matter. I have moved from the clinical more to the research side because I realized that when you go and you're talking to, let's say, the Commissioner, Dr. JB, you have to give him data and say that this is what we can do. So I'm doing a lot more on the research to understand the things that we can do to improve emergency care for our people. I think, let me stop here and let the others weigh in. Thank you.
Okay, thank you so much, Prof. Arthur. Doreen, you could come in, respond to any specific queries, but also give your part in short.
Thank you so much, Andrew. Thank you, colleagues. I hope you can hear me loud and clear. So just to address some of the things that have been asked, someone asked in regards to what is the level of preparation in the event that any of us gets an accident, you know, out of Kampala or out of the urban centers. And what are we doing to support upcountry sites in terms of training and emergency preparedness? That's a very tough question, but I'm going to try and address it. So if any of you were to get an accident, right now the Ministry of Health has established regional emergency coordinators. These emergency coordinators have a network where we have involved police. We very well know that police are usually the first responders to any incident. They have a well-controlled and well-coordinated system to alert. Their alert response is very effective, and they've proved that. We've thought of ways on how we can benchmark on their system, incorporate police as first responders, and the public trust police response. In case of any emergency, if you go down to community level, they'll tell you, we shall call police, because police have proved that they're effective in response. So we've thought of ways of incorporating police. Things have been done. The ministry has incorporated police in some of the emergency care trainings that have taken place. We have involved police in response. We have involved police in policy development. We have involved police when it comes to transportation of these patients. A lot more is going to go on with support from the ministry. Now, the regional emergency coordinators are responsible and fast. We need to find local solutions for our problem. There are many countries that are trying to develop an emergency medical system that works for them. As Uganda, what can work for us? We don't have the luxury and the tools that we have in place to stay and play with our patients. This basically means that right now, what is working for us is we just load and go. We scoop and run, right? Police helps us when it comes to scooping and running with these patients. When these patients are taken to the nearest health facility, we have to do our best as health practitioners, as clinicians, as the first clinician on site. One, assessment of these patients. Very important, but you need to be able to recognition of a critically ill patient. And this recognition comes with a certain level of skill, a certain level of experience. And this is where the training comes in. So mentorship has been ongoing. Training has been ongoing. The basic emergency care course has been enrolled in so many parts of the country, but also through the mentorship programs that have been set up in the different professional bodies. We have APO, we have the Emergency Care Society of Uganda. We have tried to make sure that we mentor different cadres and bring them on board. For this mentorship, we encourage people to increase their level of awareness for critically ill patients. But the urgency that comes with the interventions of a critically ill patient. It's very important that people need to realize that we need to be able to make a decision on when to refer, how to refer, and where to refer this patient to. Gone are the days whereby if a patient is in a facility, where referral is part of management, but it's very important that you don't just refer a patient without doing the initial assessment, the initial stabilization. And right now that we have trained personnel on ambulances, there has to be a continuum of care for these patients. Care has to be continued. You know, the chain of survival has to continue until the very end, where the patient is disposed of. So right now, training has been ongoing. I believe we are making strides in the right direction. We need to understand that when it comes to a critically ill patient, gone are the days whereby this recognition is done at the very end, but right from the very start, starting with the very first responders, who will be the borders, who will be the police, and they are very quick in making their own assessment that this patient needs to go to a hospital as fast as possible, So mentorship and trainings have taken place, but we need to get to a point whereby now we can make it an all-well system, a system that works for us, a system that can solve our local problems. And we know that our local problems are, one, we need to increase our high level of suspicion for a critically ill patient, right from the emergency department, right from the community, actually. We need to increase our level of technicality in the management of this patient. Simple things, and do these simple things excellently, all right? Putting large bore can, open the airway, etc., etc. These simple things can help to save life. So to answer that question in terms of what has been done and what needs to be done, I believe we're getting there. But we need to emphasize that let's create a system, an EMS system that works for us, that can help address our local problems. And one of the ways is we need to incorporate systems that are already working. We know that police are first responders. So how do we loop in police? How do we loop in the police communication system? Okay. If we go down to the grassroots, if we go down to the rural areas, the rural health facilities, who are the first responders in terms of the clinical spaces? The nurses, all right? Empower these nurses, train these nurses, give these nurses the skills and the knowledge to resuscitate these patients, okay? In terms of transportation, how can we make sure that there is a continuum of care within the ambulance? Empower the EMTs. Let's get to a point where we acknowledge that these are professionals. We need to professionalize pre-hospital care in this country. Let's get to a point whereby the EMTs are recognized as healthcare professionals, which means they are going to be recruited professionally, they are going to be remunerated professionally, they are going to be recognized, okay? And then right all the way to where the patient is received in the emergency department and disposition of this patient. Thank you very much.
Okay, thank you so much, everyone. And thank you so much for those who are still putting in questions on the chat. I see we are really way past time, so I wanted to bring in Commissioner at this point, who will respond and give in his parting shots, and then and also officially close our session today. We welcome all of you tomorrow at the march. We shall start at 7:30 a.m. in the morning at the Ministry of Health, but the main event will be at Millennium Grounds. Commissioner, you're welcome to come in and also close the meeting.
Good. Thank you so much, Dr. Andrew. And thank you all the members who are still on this call. I want to thank the facilitators who have, the speakers who have done their best to bring this education to the fore. My apologies, I was still with the minister. I was hearing Dr. Asfa's calling, but I could not respond because I was concluding some things with the minister. But fast forward, I want to give the comments on some of the questions. One, I think Dr. Doreen has done justice to the issue of scoop and run, and also Tom. Members, if we can educate ourselves to recognize that scoop and run is not the answer to saving lives, those who are on the roadside and others, then we shall have people providing care at the scene, stabilizing these patients before they move them. It is something which we need to do a lot, and it will help when the police go on the roadside and they are picking some of these injured. They will know that the actual first step is to provide stabilization to these patients, not to just put them under and move them. I think that is one area which we need the new training. We recently added the National First Aid Training Manual approved, so we need to utilize it so that even the police can do the stabilization of whoever is at the scene of emergency. Dr. Aspas had asked the issue of training and absorption of the people who are trained. I want to appreciate Seed Global Health. We have scholarship opportunities. 20 emergency medicine physicians every year have been sponsored through Seed Global Health. The only challenge we are having now is attracting the candidates to these universities, Mbarara, Makerere, and Uganda Matters University in Zambia. If people utilize this, that will be good. In the National Development Plan 4, we have indicated by 2030, we should be able to have trained about 1,266 emergency medicine physicians to fill our spaces in government and in the private sector. Secondly, we have the paramedics. Recently, the First Lady approved the curriculum for training the paramedics. The diploma curriculum was approved, and now officially we shall be training the paramedics. And you know, the revised structure for staffing for national hospitals, regional referral hospitals, general hospitals, call and dispatch centers, all of these places have paramedics, and we can have them recruited when they are trained. So first, Lubaga, Zambia, and Gulu are the training sites. Soon in Mbarara University, we'll have the Senate also approve the revised curriculum so that the paramedics will be trained there. Members, I want to emphasize that we are establishing call and dispatch centers which are going to help us in terms of response. Someone should be able to call using a short code 912 and is assisted as such. So far, we have Mulago, we have Naguru, we have Masaka, we have Arua under construction, Lida under construction, Mbale under construction, and Mbarara under construction. So those centers will help in terms of coordination. The National Ambulance Service, already Annette commented on it. It is operational despite of challenges, and we are advocating for more resources in terms of operations, fuel, and other things for it to function better. The policy also provides for emergency units at all levels, from health center 4 to the National Referral Hospital. So the government is slowly establishing these units. So far, all the regional referral hospitals have assemblies. We have also planned in the National Development Plan 4 to establish trauma care centers at national and regional levels. And this, I believe, in the next funding cycle, we shall start on this. Naguru National Referral Hospital has been designated to become the first national trauma center for the country. So we think that more will be built there. Dr. Professor Kwezera did a lot of justice on intensive care units that we in the chain of survival, we cannot do without intensive care units. Also, on top of the intensive care units, at the end, when these patients are discharged, we need those to connect with rehabilitative centers. So all of these are going to be very well outlined in our revised strategic plan. I want to appreciate Malteser International. They have committed to get for us a consultant to have us develop the strategic plan 2 for EMS. And most of the things which I'm mentioning in passing are going to be detailed in the strategic plan 2. I want to thank you all and ask you to come in large numbers to the Emergency Medicine Day tomorrow. The Minister of Health will be our guest. She'll flag us off at the Ministry of Health quadrangle. Then she will also address us at the KCCA grounds. So let us make this day. This is an advocacy forum. Majority of what we are talking about, people out there may not understand them the way you have understood them, the way our speakers have said. So let's make a point so that people can come out and say, oh, what is this being talked about? And then we can get the support which is required. Thank you so much. I want to really appreciate the sponsors for this webinar and all the people who have been able to attend this webinar and all the speakers. Thank you. This is closed. Thank you.
Thank you so much, Commissioner, and thank you everyone for attending. Looking forward to seeing you.